looked down.
No.
The patient was peeing, and it was you're in these stupid blue scrubs.
On you?
Yes, on me. And it was like right here where it looked like I would pee myself.
Like you peed yourself?
And I just felt stuck. They own everything. If you wanted to go to a private practice, your wage would be dropped significantly. And that was just kind of what they did to control everything. And I hated it. But for that 90 minutes, it's dreadful. Like you're sitting in the operating room. You've got everything ready to go, and you're basically just watching the screen.
What's up, guys? Welcome back to another episode of the Device Girls. Today we have Jenelle Barassa, and she is an OR circulator here in Abilene. So we are so excited to have her, and we're gonna talk all things OR. This is like Sarah and I's, kind of space and realm that we're familiar with. So we're super excited to share. So go ahead and
see the nursing side of it.
Yeah, right?
Yes. So excited.
Thanks for having me.
Yes.
I'm super excited to be here today. My name is Jenelle. I am an OR circulator at Hendrick Health. I work at the Northside campus and the Southside. Originally from Canada, but I now live in Abilene. When did I finish nursing school? Graduated in December of 2019. And then I got into the peri-op program the following September in 2020. So, gosh, it's almost been like 5 years. 5 years in the operating room.
So did you do nursing school here in the States or in Canada?
I did it in Canada.
Okay.
Yeah, in Calgary. Graduated from Mount Royal University.
Oh, awesome.
Yeah,
awesome.
Great program.
Wait, I'm curious what brought you to Abilene?
So I was doing some travel nursing the last 2 years before moving here. And I went back to Canada and was like, I do not want to be here. I never wanted to go back to the healthcare system there. I had a friend that was in Seattle. She was doing some travel nursing there, and she got me on board to get the visa screen and all the documents. It was the lengthiest process ever, like 6 months to get everything finalized to get down here. It was a lot of work, but I'd say it was worth it because I love it here. But my husband, he was the harder one to kind of get down here because he is an electrician, and for some reason, trades is just not wanted or desired down here. So he knew a friend down in Houston that actually gave him a job offer. So that's how we ended up in Texas. And then I came down with a company that specializes in sponsorship rather than travel nursing. Yeah. And I was actually a little bit surprised, but in all of Texas, they only had 2 locations, and one was here or in Wichita Falls. And I chose here. Yeah. All of Texas.
Good choice. I'm glad
I know,
you did.
me too.
Oh my gosh, that's awesome.
Yeah.
Okay, so tell me a little bit about the perioperative program that you went into after nursing school.
So that one was offered. I think they do like groups where they kind of clump you in. And I think there was only 4 that got into the one that I was in, and then one ended up not making it. But you basically just start, most of it, you're in the hospital, in the OR, but a lot of it is just classroom computer work.
Okay.
And I think the Peri-Op 101 course is American, because I remember some of the terminology was a bit different than what we were used to in Canada.
Okay.
So a lot of it is just getting through modules, doing little exams on the computer. And then Fridays, we were able to go and do observe in the operating room. So our educator would just kind of put you in a room, and you would stand in the corner, and it was good to get rid of the nerves, to be in the operating room, because it's, when you're new, it's terrifying. So you'd kind of just sit there, you would do what you were told, and you'd get to watch the surgeries and stuff like that. But that was a good, I think, 6 months of that before we started like actual orientation.
Oh
wow.
Yeah.
Okay. Awesome.
It's lengthy.
So what made you want to choose the OR?
Yeah.
Like out of all nursing,
I know.
Why the OR?
So my biggest thing was, have you ever heard of Doctors Without Borders?
Yes.
That was my number one reasoning. So I love traveling. It's my number one passion in life. And I had just gotten back to Canada from living abroad in New Zealand and Australia for a year.
Oh my God.
Oh, wow.
And when you come back from holiday and you have like those 2-3 days of depression where you're like, I don't want to be here.
Yeah.
So imagine a full year of being away, living your best life, and then coming back to reality. But I was sitting at my mom's house, and it was daytime TV, like 1-2 p.m. There's nothing on, but they were like, the Doctors Without Borders were on TV. And I remember it being like the doctor and the surgical team, and they were in Africa, and I can't remember what they were there fixing or doing surgery on, but I was like, that's kind of it. I told my mom, I was like, I'm going to go to nursing school. I'm going to go straight to the operating room, and I'm going to get on a flight to Africa after I graduate.
Oh my gosh.
I didn't go to Africa,
Okay.
but
I was like, so.
so travel
Did you
nursing
go?
to the U.S. was my
Yeah.
compromise.
Okay.
Oh, that's awesome.
I met my husband right before nursing school, so
Okay.
going away because the Doctors Without Borders it's different requirements for like surgeons, registered nurses, or whoever else goes. But I know when I was looking it up for an RN, you have to commit to a minimum of 6 months.
Oh, wow.
And my husband was like, or not.
Or not.
I was like, okay.
Yeah.
So then, like my friend that was in Seattle, she was doing the travel nursing down here, and I looked into it, and I was like, would you let me go down to the States? And he was like, yeah, sure. So got that ready, and that's kind of why we're here.
Yeah.
So yeah, can't complain.
But y'all are going to stay, right?
We're going to
Hopefully?
stay.
Okay.
We say often, like we will be, driving somewhere, and we'll both just look at each other and smirk and be like, we live in Texas now. Like we just think it's so cool.
Yeah.
We're both super happy. I think we're both happier being here than we were back home. So big changes, but I don't know. We think it's been really good.
Yeah.
So
That's awesome. Oh, I'm so happy. That's awesome.
I'm actually kind of curious, and we don't have to open this can of worms right now, but like you mentioned the difference between healthcare, like Canada versus the US, like
huge difference. Pros and cons to
Really?
both. I don't
Okay.
want to, I'm definitely going to have people that are like,
Oh,
some
I
are
know.
for this and some are for that.
Right.
But
Yeah.
I just think that, so in Canada, we have provinces, and each province has like a big kind of public sector that I would say runs the entire healthcare system. I was from Alberta, so it was Alberta Health Services.
Okay.
And I just felt stuck. Like there's no competition. They own everything. So, and then if you wanted to go to a private practice, your wage would be dropped significantly. And that was just kind of what they did to control everything. And I hated it. I just felt super stuck. And like the wait times, like for a total joint, you're looking at 1+ years.
That's insane.
It's insane.
Wow.
Even getting in for like an MRI, like you're waiting like 6 to 8 months.
Oh my gosh. And
Yeah.
that could be a scan for cancer or for.
Those ones will go through for
Okay.
sure. But like, even if you're having, like when I came here, I was having back pain, and I got to see doctor, like within a week, I got all my appointments done.
Yeah.
It cost me a little bit of money, but it also didn't cost me as much as most Canadians think. Like they just think that healthcare down here costs a ton of money. And I'm sure it does in some aspects. Like I don't know too much of that, but I just think it's great down here that you can be seen a lot quicker than you can up there. So
Interesting.
Yeah.
Yeah. I like hearing like different perspectives because I've never lived in Canada, so I don't know.
it's different. And I know a lot of people
Yeah.
will say like one of the benefits is you can just go into the ER and have something done. You don't have to worry about getting a bill. You don't have to worry about having insurance. So that is definitely one of the pros of Canadian healthcare. But like I said, pros and cons to both.
Yeah.
So far, my husband and I have both we've just had a better experience down here.
Well, I think
It's
like
amazing.
if you are provided healthcare through your, your job, then oftentimes, like yes, you're still going to receive bills or have copays and stuff, but oftentimes, I mean, I think I'd take that over having to wait being seen for
A long time.
Mhm.
Like the wait times in the ED is insane
really.
unless you're like in excruciating pain or you can't breathe. So
Oh my gosh.
pros
That's
and cons to
crazy.
both. But
Yeah.
yeah, like I
Yeah.
said, so far
Yeah.
we've had a better experience here, both
Yeah.
of us. So
That's good.
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 Good to hear too.
Yeah. Yeah. Yeah.
Welcome to Texas.
So you mentioned some of like the terminology being a little bit different.
yeah, what's the
between
difference?
what-
in that?
Oh,
Like-
like silly little things. Like we would
Okay.
say, what do they say here? So they say tourniquet here.
Uh-huh.
Mhm.
We say tourniquet back
A
home.
tourniquet.
Oh
Yeah.
wow. Okay.
I guess Bovie, they call it Bovie here. We call it cautery back home.
Okay.
Yeah.
Like just
Okay.
simple little things that when
Yeah.
I first got here, I was like, what is that?
What are they asking for?
Right?
Yeah. Yeah. That's so funny. Okay. What's your favorite type of specialty to be in?
Mine's orthopedics.
I know.
I know.
Which makes me so sad. I'm like-
I know. I do like the mix. I'll do orthopedics every day until the day that I retire, but it is nice sometimes to go sit in like a 6-hour robotic case
Yeah.
because ortho's hard. It's fast. It's high turnovers, but
Yeah.
I just like it. I like the procedures. I like the instruments. I like the teams. I don't know.
Yeah.
Yeah.
What
I love
about ortho? Like besides the instruments, like
I think it's just because it's
What's your
loud.
favorite word?
Yeah.
Okay.
It's just loud. It's busy. Like
Yeah.
you're always moving, and then they're closing, and you're on the next case, and then
Yeah.
it's the same thing. So
Yeah, you'll
it
flip
is
back.
exhausting. I think it's
Yeah.
definitely a lot harder on the body than most specialties, but
Mhm.
I don't know. It's fast. It's loud. It's rowdy.
Yeah,
Super fast
Yeah,
paced.
it is. Yeah.
I was in ortho before where I'm at now, and yeah, like there are times, like most of the time, I don't know if you guys do this here, but 2 rooms back and forth. Now
Always
there's 2
flip.
different nurses
Yeah,
in there, but
that's what
like
we're
you're
doing on the
go,
south side.
go.
Yeah, it's insane. Doctor moved to the south side to do that, and
Mhm.
ugh, I go home and I'm beat. Like I'm
Yeah.
like, okay, it was fun and
Well,
it's
I feel like
busy.
y'all came through like 10.
We do 10. So he'll
They do.
do
Wow.
4 or 5 totals. And then the other room, so we'll have one room of totals, and then the other room will be sports med.
Yeah.
But he is so fast on his
Yeah.
sports med cases. Like he's a fantastic surgeon. But yeah, he will like
You're just like-
carpal tunnel in 8 minutes, and you're like, okay, we're not even, the patient in the other room's not even out yet. But I think it's going to be really cool once we're there. Like
Yeah.
we're obviously going through transition, and everyone's kind of still learning the ropes. But
Yeah.
it's just really cool that they can
Mhm.
get that many surgeries done in a
Oh,
day.
yeah. Their teams 100% operate like you're at a surgery center.
Yeah,
In and out.
definitely. I know we always told them, we're
Yeah.
like, why don't you guys just open up like a total joint clinic? Come on.
Yeah.
Well, I tell Sarah all the time, it's so interesting to me because like in Dallas, that's a huge thing. Surgery centers everywhere, and everyone's more like private practice. There's a few that are hospital employed, but
Mhm.
so it's such a different dynamic because a lot of total joint cases like are rarely at the hospital anymore. They're all
Oh, dang.
surgery centers out
Yeah.
there, and that's all they're doing, cranking
Mhm.
out
Yeah.
joints and whatever, which
That'll
is
be
cool.
the dream.
Joints and sports
on,
med and
Open that clinic. Let's go.
Yeah. That's awesome. Okay. Can you walk us through a day in the life of a OR circulator?
Yes.
Like what does your day look like? What is your role specifically in?
Also be real about it. Like what time do you wake up in the morning?
So I mean, if I didn't have my dog, I'd probably get up at like, I'm an early riser. So
Yeah.
I know I have friends that are like, I get up at 5:30, 5:45, and I'm at the hospital at 6:30. And I'm like, how? I like to get up in the morning at like 4:30, 4:40,
Okay.
Mhm.
drink my coffee in peace. But get to the OR. It's nice to know the day before
Mhm.
who you're going to be with. And if you do have a chance to quickly look up your patients, it kind of soothes my mind to know a little bit of history about my patients when I do
Mhm.
get my report from the pre-op nurse. So if I have a chance, I'll do that the day before. And then when you get to the hospital, you have your huddle with your team.
Okay.
Then we head to the ORs. Scrub techs will kind of start doing their thing, which is opening up the back table. On the nursing side of things, I will just make sure that we have like the right bed, the right positioning devices, that the like instruments, not the instruments, technology side of stuff is all turned on. And then I'll go pull meds, get any irrigation stuff that we need. Once that's all set up, then I'll help the scrub tech open the back table. And then once they're good, once anesthesia's in the room and they're all set up, I'll head to pre-op, get my report on the patient. And then if the room is ready, then I'll bring the patient into the operating room. We'll help get them transferred from the stretcher to the OR bed.
Mhm.
And then you'll help anesthesia with intubation.
Okay.
And then once that's done, you'll help get the patient positioned and prepped.
Mhm.
And then that's when the surgeons will come into the room and they will drape the patient. Scrub techs will throw everything off and they get everything plugged in. And then you do your timeout. And then once your timeout is done, once they're all kind of set and ready to go, that's when I get all my meds on the back table, irrigation, and then I will just start my documentation.
So what does that look like? What exactly are you having to log each aspect of the case? Like, hey, we're here. I mean, is that how it stays updated on the board? Is what you're logging throughout?
Yeah.
Okay.
So it's the time in, the big ones are your time in the room, your
Mhm.
time out, and then your procedure end time. And then your patient exit time is once we get them to pack you.
Okay.
That's the exit time.
So real in, real out.
Yeah.
When you're measuring. Okay.
And then that exit time is also your 20-minute turnover time, which we all hate, but very important. So those are the things that you document. The documentation can get a bit repetitive, but
Okay.
it is what it is. It's the legal part of it all.
Yeah.
So since you do a lot of ortho too, I think it's important to note, like, what do you do when like a rep like us gives you stickers for implants or like, because we do that all the
All
time.
the time.
Does that ever get monotonous? Or I know that now I think it's to a point where once you've used, like if you have the same rep all the time and you've used these implants, most of the time aren't they like in the system already? So it's
They
easier?
are, and it is a huge pain in the butt when they're not. And I
Yeah.
feel like Zimmer is in there, Stryker for some reason is not. And
Yeah.
I don't know-
Really?
I don't know
Okay.
why,
Mhm.
but if you have to do a generic, it is the most annoying thing on the planet.
And sometimes there's like 5
I
stickers.
know, right? So it is like, especially with joints, it's the same way all the time for
Mhm.
most surgeons.
Yeah.
So it does get a bit repetitive, but that I like that because it makes, I know what I'm doing.
Mhm.
That's
You
true.
finish the case and you're like, you don't feel incompetent because there's some specialties I go in and I'm like, oh, thank- that's over.
Yeah.
But yeah, so if the implant is in there, it's just a lot quicker.
Yeah.
If it's generic, you're typing everything out and then you're like, ugh.
Yeah.
Sometimes I won't even get them all in before the case is done. So you just have to
Yeah.
do some charting after.
So, how does the team make a difference in how the flow of the OR happens? I mean, like, what does that look like? How do you try to foster like really good teamwork and like moving and
Yeah.
grooving? Like,
I feel
What
like
about
that
you?
honestly makes or breaks your day.
Yeah.
It is so, we work so closely as a
Mhm.
team in the operating room. Like one can't work without the other. Like you
Mhm.
need every single person in there in order for it to work. So teamwork is just, it's super important to communicate. It's
Mhm.
super important to respect the roles of your colleagues. I mean, no matter what, we're there for the patient, but yeah, it's just about communication and respect
Mhm.
because one can't work without the other.
Mhm.
And when you're in a room and the vibe's not there,
Mhm.
it sucks.
Yeah, it
But
does.
when you're in a room and
You're like,
it's good,
"Yikes."
like you finish your day and you go home happy. Like you
Yeah.
feel good. But I tell you, when you're in a room and there's tension or there's,
Yeah.
Mhm.
and that just goes to show how closely we work together.
Yeah.
Because I feel like when you're on the floor or, maybe in ICU, you work independently a lot.
Mhm.
And so you don't have other people's moods affecting you as much,
Mhm.
but you feel it in the OR for sure.
Yeah.
Mhm.
100%. And then that really sets the tone for how the surgeon acts.
Correct.
Yeah.
Yeah.
And we want to keep them happy. Yeah.
I always try to go in sometimes if like scrub tech's in a bad mood or whatever, and I'm like, well, gosh darn it. I'm like, good morning.
Yeah, I know.
Wake up.
Yeah.
We're going to have a good day.
Oh,
Yes.
I
And
try.
I feel like too, it's so, our charge nurse does a really good job at trying to keep, and it's like, oh, well, these people are always in the same room. It's like, well, they're always in the same room because the surgeon, they know what they're doing in that room.
Yeah.
The surgeon likes them. And it's like, happy wife, happy life. I'm
Yeah.
like,
Yeah.
happy
Yeah.
surgeon, happy day. Like
Yes.
just do it. Just keep
For sure.
keep the people. And like, we all understand that at 3:00, a lot of staff goes home.
Mhm.
So then at that time, like, I think that's when surgeons are a little bit more lenient or okay with a different team coming in. But I'm like, until 3 p.m., if you can keep the room happy, please do.
Yeah.
Mhm.
Keep those teams in there.
Yeah.
So
What was the learning curve like? I mean, of course, like y'all go to nursing school. I mean, in-depth education, but when it comes to the procedures, like what was that learning curve like stepping into all of these various specialties and cases? And then you're like,
it was intense.
Yeah.
It was terrifying. I really do think that it really boils down to your preceptor.
Okay.
Like if you have a fantastic preceptor,
Mm.
that makes a huge difference.
Mhm.
Like I remember I was in GYN and
Okay.
Okay.
and it was back in Canada and
Uh-huh.
her cases were like 12 to 16 hours long. She had all the super hard, like endometriosis, like
oh, wow.
super, super hard. And I was scrubbed and I was just a little baby scrub nurse.
Yeah.
And my preceptor was not even in the room. And I had another nurse that came in and she was like, where's your preceptor? And I was so over my head. And this nurse was amazing. She like helped me clean my table up. Because in Canada, we do both. We scrub and circulate.
Oh, okay.
Oh, wow.
But
That's awesome.
yeah. So I haven't done it since I've been here. I don't
Yeah.
really miss it, but just having that, she made such a huge difference that I was never with that preceptor again.
Okay.
They actually didn't
That's
put students with her because doctor was like, do you even know what you're doing? And I was like, I
No.
don't. This is my
No.
second week
Yeah.
scrubbing as a nurse, but it's the same thing with circulating. If you have someone that will help you learn, it just
Mhm.
makes a huge difference because it is not like any nursing that you're going to do. It's not
Yeah.
like I feel like floor nursing, same but different for ED, same, for
Mhm.
ICU, you're still out there. But when you go to the OR, it's like,
Yeah.
what am I doing?
Yeah. For sure.
Now,
What-
are there like
yeah.
some certain basic like tools or whatever that you would use in any OR case, basically, no matter what specialty you're in?
I'm gonna say scissors. Nursing
Scissors.
scissors.
Scalpel.
Right.
And you know you're always going to do like a gown and glove.
Yeah. I think
But-
the big ones, especially like they'll say to no matter what, especially if you're having like bleeding or anything,
Mhm.
suction, Bovie, and lap sponges.
Mhm.
Those are like the three that you need. It's the same thing if you have like suction with anesthesia.
Yeah.
Okay.
Like
yeah.
those are the three.
Yeah.
When in doubt, suction, Bovie, lap sponges.
That's it. Yeah.
Yeah.
Most important.
Yeah.
That'll get them started.
Yeah. There you go.
Okay. So actually, that brought up a good point. Walk us through like doing your count and stuff with the scrub tech,
Yes.
because that part was
Okay,
wild.
I've always wondered this because
Yeah.
sometimes, and obviously I am focused on other aspects of the procedure and case, but sometimes, like, do you always mark, or like, are y'all just really good at tallying in your head?
So, I mean, everything in the OR is based on policy.
Okay.
Everything. I would say that the counts that I have done here have been a little bit different than I'm used to.
Okay.
In Canada, we have a count sheet, like a paper count sheet,
Oh, okay.
and you put a patient sticker, and the front page was always your softs.
Okay.
So that's like your sutures,
Yeah.
your lap sponges, all that small stuff. And then when you opened it, it was in sections. So you had your general pans, your ortho,
Got it.
not really ortho because you wouldn't count those instruments, but anything when you were actually having to open like vascular,
Yeah.
and you would put a little 1 or a 2 or whatever, and then
How
so
many?
everything, and then that followed the patient straight through to recovery. So when I came to Washington to do travel nursing, and I was like, what do you mean I have to write on a whiteboard?
Yeah.
So it's just different. You just kind of do, some people have it on a little piece of paper, or like the little the gowns have that little cue card thingy,
Mhm.
Uh-huh.
and they'll do it on that. I mean, the right way for policy is to do it on the whiteboard with
Okay.
like the patient name, the procedure.
And you just count and tally.
Yeah, you
Yeah.
count and tally. But I would say like when you're doing like when you have to count all the instruments, a lot of us will put it on that piece of paper
Mhm.
just because you're already using that piece of paper.
Mhm.
And then I will just take my softs and go write it on the whiteboard,
Oh, okay.
so that if I'm getting relieved for lunch or something, then that nurse can come in and they'll see that
Pick
it's
up
on the board.
exactly.
Yeah.
Yeah.
But it is so different from every facility
Yeah.
that you work at.
So,
So-
everything that you're going to count, walk us through that. Like, what do you start with?
So you can, I always leave it up to the scrub nurse just
Mhm.
because it's their thing.
Okay.
Some people will say it's up to the nurses, but I'm like, it's their field. You start with what you want. So if
Yeah.
you're doing any abdominal surgery where we have the potential of opening,
Mhm.
you have to count your instruments.
Mhm.
So they might start with instruments first, and then a lot of them are really great at starting right from the top.
Mhm.
And then you'll just list it off and go right through. If it's robotic, we have to do the accessories as well.
Mhm.
And then you'll move over to the softs, which are like your Ratex, your laps, your blades,
Mhm.
your injectables, sutures,
Yeah.
any of the little things. Like neuro has a bit more. They got the little neuro patties. So
Okay.
Mhm.
Yeah.
Okay.
I was pleasantly surprised though. Here they don't. Well, I don't. Maybe we just count everything in Canada, but like marking pen, ruler, the little trocars
Uh-huh.
on the robotic
Uh-huh.
things, we counted all of those. If it had
Really?
a rubber cap, if you could take it off and it had a rubber cap,
Oh,
we
wow.
counted those.
Okay.
So it was like the first time I counted here, I was like, trocars? They're like, what are you talking about? I'm like, okay, never mind.
Yeah.
That is an interesting point. How
Yeah.
stressful is it? Okay, wait. Let me ask this question first. So, how many times do you have to do a count?
So you have to do it. So initial count is your first one.
Okay.
And then like for, let's just say we'll do like a total joint versus a big
Mhm.
Robotic surgery. So total joint, you're not getting relieved. No one's coming in to relieve you because it's, you can't, the surgeons won't let you, like no one can come in and out of the rooms
Switch,
for that.
yeah.
So you do your initial, and then you'll do a second count when you're closing capsule, and then
Mhm.
when you're closing skin. So you're only going to do 3 counts on that one.
Yeah.
But when you're doing like a big belly case, you'll do your initial. And then if you don't open, you'll still do closing fascia. And then when you do your skin count. So
Okay.
there's still 3 no matter what.
Okay.
But then you'll add in a count if you're getting relieved for lunch.
Mhm.
So when I'm going into a room, I'll just do a quick count of softs.
Okay.
Because that's probably what I'm going to have to count if we do close.
Right.
Plus, it also just gives me an idea of the count is correct if that nurse is going on break.
Yeah.
Because if there's any discrepancies, then you have that nurse in the room to be like, hey, I'm missing a suture, or
Yeah.
and then that gives that nurse and that scrub tech time to figure it out. If it's wrong, most of the time they're right.
Yeah.
So I just do one just to be sure.
Yeah.
So how stressful is it when the count is off?
It sucks.
You can't find somebody.
Oh,
Mostly because per policy, we are not supposed to, the surgeon's supposed to stop closing until you find. They never do. So you just try your hardest to find it. We're vocal. I'm like, hey, we're missing this. Like, we need to find it now. And you just hope that you do find it. And then in the event that you don't, you have to get x-ray to come in and do an x-ray. And then they have to do an x-ray, and then radiology needs to phone into the room and speak to the surgeon to clear it before they're technically supposed to close.
Yeah. So
it's a big deal, and
Yeah.
it does delay things. So that's why if I'm coming in for a lunch or something, I'll just do a quick count of softs just to make sure that we have, because otherwise it's a nightmare at the end when you're like, oh, I don't know if I did it wrong or if it was wrong before. So
Yeah.
Important.
We've had there's been a couple times I've been in cases and there's been like, hey, we're missing a ray tech or whatever. And so, they got to bring radiology in. And then thankfully, I don't
or
think.
you pop a needle and you're like,
Oh,
where
yeah.
is it?
or like in vascular,
And the
back
needles are
home,
the worst because
Oh,
they're
they fly.
yes. We had when they're super tiny sutures that you can almost not even see. And you're like, how am I supposed to find this? And you sometimes the scrub will be like, oh, it's right here. And you're like, yes.
You have the best eyes.
Totally.
Oh my gosh. Yeah. Yeah.
Well, the worst is the needle. And if it pops on the floor and
Or in the patient.
and the table's in the
Yeah.
way, and you're like,
Yeah.
They do have these fancy little magnetic rollers.
Do they?
Yeah, there's two. I
I'm
think there's
waiting
one or two.
for the day that somebody, I probably shouldn't say this on camera because what if I want to invent it?
patent.
But somebody, don't steal my ideas, make a magnetic instrument that can go in through a trocar
Yeah.
and it just will pick up whatever. If there's a needle that got popped in, and it
Even
flies.
little staples.
Yeah. Oh,
That
they
would
can
be-
pick up everything just
Yeah.
like a vacuum.
That would be
those
great.
metal detectors that people use at the beach. That'd be great. You know how
Yeah.
much time that would save?
Yeah.
Oh, yeah.
mm-hmm.
All that counting would.
But I don't know if regular people listening know this, but a lot of these things like laps and Raytex, you can see them on imaging.
Yeah.
So
Yes.
it's helpful.
Yeah.
Yeah.
It's just a
Just-
pain. That takes
Yes.
so much time.
it just delays the day.
Oh yeah.
And that's the biggest thing. They're just
Yeah.
oh,
Yeah.
Or
And
I
then
don't
the
know if this
surgeon's not a happy camper.
no.
I don't
typically
know
not.
if this happens here, but there are times I shouldn't bring this up, but we can't find certain instruments. They got thrown in the trash.
What is the craziest story and thing
Yeah.
that you've ever? Because I've had surgeons tell me some whack,
Things.
A freaking massive retractor got
Yeah.
left in a patient,
What?
or
Ours was, we had this thing in Canada. It was bright yellow. So I don't know how it got left in, but it was called a fish. And they'll put it in. So when they're doing a big belly one, they'll put it in like this. And it just helps keep everything in while they're suturing the abdomen shut, just so that it's not everything's in place. It's not coming out.
Mm-hmm.
That got left in because I was like, why do we count this big yellow thing? And they were like, because someone here left it in. And I was like, how do you leave this bright yellow thing that looks like a fish in an abdomen? But I think it's because you just they're they're not thinking about it. They're just like, okay, let's get this abdomen closed. But yeah, that got left in. It wasn't, I don't think it was when I worked there, but that's the craziest thing I've heard.
Yeah, I had a surgeon tell me one time that it was either them or their partner. They had a patient come in and they ended up going in because they thought it was like a mass or something, but this person had a hysterectomy and the surgeon, the specimen in the body
Oh, dang.
left. Yeah, that's what it was.
E. That's a
Just
bad one.
your rotting necrotic uterus just chilling. Like, what? That is why it's so important. Do research on your surgeons,
Yeah.
people. And
Even I don't know. Yeah.
there's so many good surgeons. I mean, we have incredible surgeons. All of our surgeons.
Mm-hmm.
Come to Abilene. Abelene's got great surgeons.
Yeah.
Dallas has great surgeons too, but there are some. Dr. Death, don't look him up. We had a professor though who was in a case
with Dr.
with
Death.
Dr. Death.
Mm-hmm.
Doctor, what is his last name?
Doctor, I can't remember his.
Dr.
Well, no,
Dead?
everybody.
Well,
calls
Sarah,
him
but
Dr.
a lot
Death.
of the docs that I work with, they all worked with him. They all had to go testify against him in court.
I
And
can't remember his name.
Here,
but
or is this in Dallas?
He got
In
called, I
Dallas.
mean, his name became Dr. Death because he was a serial killer essentially.
he was a neurosurgeon.
But he was a
that-
neurosurgeon who was like killing his patients or injuring his patients on purpose in the OR.
Wow. Wow.
Crazy. I don't know how
Yeah.
anybody can get into healthcare and be like, I want to hurt people. Like, this is just not
I
the
know.
space for that.
Yeah, especially the operating room.
Yeah.
Anywhere, really. Like your
Yeah.
literal job is to care for other people.
Like that surgeon that took out the freaking liver instead of the spleen.
Oh
down in
yeah,
Florida.
that one was crazy.
I'm
I
sorry.
did see that.
They look like
They're
two
on-
different.
And on different sides of the body.
Yeah.
How? How?
Yeah. Questions. All the questions about that one.
What has been the most impactful surgery or case or patient that you've ever experienced? Like one case that just stuck with you, has kind of shaped you as a nurse.
Oh, there's so many. There was one that Alex, so I was redeployed to the ICU like 3 times during COVID back home
Okay.
in Canada. We were basically like glorified healthcare attendants, but it was really cool opportunity to see the ICU without actually being like ICU employed. But there was this one lady, it was so sad. She had an esophageal varice
Okay.
that ruptured.
Yeah.
And they had this contraption that I had never seen in my life. And it was so barbaric looking. It was like this frame that goes onto the bed. And then there's something that goes down her throat that tries to, anyway, but it was just, I mean, they're all really sad and awful, but she wasn't very old. But maybe it's just because me and the other nurse, it was like 5:30 in the morning and she was bleeding from everywhere. But anyway, she passed away. And I don't know if it was just because her and I, it was like the sun was coming up and her family had gone at that point, but we were just, you have to get the body ready. It was hard. I just remember being like, I went home that one and I was like, yeah, that's tough.
What does that look like when you have to get a body ready?
They're cold. They're like kind of a yellowish gray color. You speak to them like you normally would if they are alive. You just say that we're going to get you cleaned up and you treat them with respect. I always just say a little prayer for them. And then you just treat them with dignity and respect like you would anyone who is not passed away. And then you'll get their body into the morgue bag and you'll mark them and then you'll cover it up and the morgue people will just come and transport them down to the morgue. But I would say with any body that you're dealing with, it's the same thing when I was redeployed to ICU. Like there was a lot of patients there with COVID that were intubated and you speak to them like you normally would. Like, hey, we're going to brush your teeth or we're going to do this, or we're going to do that. And because they can hear you. And I don't know, I still believe that even if they're deceased that they can hear you. So
yeah. Wow. That would be hard.
Yeah,
That would be really hard.
It's hard. It's hard, but I don't know. I like to think that in the operating room, most of the time we fix people. It is kind of why I like it. Right?
It's very
it really
rewarding.
is.
Yeah. You're coming in and we're going to fix you. We're going to get you out of pain, hopefully, or, give you that new hip or something, take that part of the colon out that has cancer. For the most part, I think that it's a happy, it's a better unit, but those incidences do happen and it's just.
Yeah. It's sad. So sad.
So you mentioned that since we're talking about that, you mentioned you wanted to talk about organ donation, right?
We were, it was
what?
I guess it was. And it was like your long day.
Yeah.
And there was a organ donation case. And walk us through what that looks like.
So those are the ones that I think are the hardest to date in the OR to deal with. And I don't think they ever get easy. But there are 2 kinds. The only one that I've seen it has been the DCD, which is donation after circulatory death. And then there is DBD, which is donation after brain death.
Okay.
So I have done one DBD back home in Canada. That one's a little bit easier because the patient is already declared brain dead. So they are being kept alive by the ventilator, and that's just to keep their organs perfusing. So with that one, you have more time. You go to ICU with your anesthesiologist. You'll bring the patient into the OR, get them onto the bed. Anesthesia's in the room, and then the organ procurement team will come in. They'll get the organs that they want to get, and then once they have that, they close the patient up, and then anesthesia will pull the tube. The patient typically dies almost right away, and then you'll get the body ready and send them to the morgue. But DCD is, I think it's so hard. So the patient, they have had like a severe brain injury. So they're still alive. They're still breathing. Their heart's still working. They are usually being ventilated to help with that. But so with that one, you'll still go to ICU. You'll get the patient, but there's no anesthesia that comes to the room. It's the ICU nurse. But you'll do the same. You'll get the patient onto the table. You'll get them prepped and draped just as you normally would. And then the organ procurement team is there. And so they'll make sure everything's good to go. So with that one, they'll leave the room, and then the ICU nurse will pull the tube, the breathing tube. And I don't know how it is elsewhere, but you have a 90-minute waiting period where the patient has to pass on their own.
In that 90 minutes.
In that 90 minutes. So you're all ready to go, like to cut skin, to do surgery if needed. But for that 90 minutes, it's dreadful. Like you're sitting in the operating room. You've got everything ready to go, and you're basically just watching the screen. I haven't had it here. The patient has passed. All of my experiences here, the patient has not. So, and then the hardest part is we will leave one arm out under the drapes so that the family can come in and be with the patient. And sometimes that patient is like, they're gasping, so you can hear them trying to breathe. Sometimes they're moaning and groaning. Sometimes it sounds like they're breathing and they're alive. And you're like, it just makes you feel like, should we be doing this? But you understand that they're not there. Like they have so much brain damage that they're, but that one's the hardest. And then if they do not pass, then we'll get the family out. They'll go back to ICU. And then we'll just tear the drapes down and put the patient back onto the ICU bed, and we'll take them back to ICU where they will eventually pass away. That one's the hardest.
So are those all patients that have signed like a DNR?
I don't know. I think that it's either, so I think what happens is they'll either have signed before anything happens that they do want to be an organ donor, or it's if the injury happens and the family makes a decision that they want to donate the organs. So these patients have probably been in ICU for weeks, trying to do the best that they can. And then the doctors made a decision to say, hey, there's no coming back from this. They've got severe brain injury that they're basically going to just be a vegetable forever. So then the family would decide. They probably have the organ procurement team come in and talk to them about the, organ donation program. And then they would make the decision of, yes, we want to, or no, we'll just let them pass. But that one's hard for everyone too, because the recipient, right? Like you're being called and, hey, we have your lungs for you, or, and then you're getting the phone call that the patient didn't pass, so you're actually not going to get your organ.
So, and how does that work? Does that mean that on the other side, that patient is prepped, ready in the OR, ready for them, basically same thing, ready for them to make the incision? We are, yeah. So that, like, they're ready. We have everything plugged in, like, because that one is, there's a very small window. So once the patient, if you're watching all the vital signs, if the patient does pass within that 90 minutes, they've got to cut skin and get those organs out real fast. Whereas with the brain dead one, that patient is being oxygenated and kept alive through anesthesia until they get the organs out. So there's no time frame. But because we have to let the patient pass on their own, once they pass, there's no circulation going to those organs anymore. So they have a very specific time frame to get those organs out and get them back perfusing. So, and then how do we have an organ procurement team in Abilene? I don't think so. I think they all come from Dallas. Really? I think, or somewhere. Okay, I don't think we have them here. It does have to be a pretty well thought out plan of hey, we need this team here. We need to know potentially who this is a match to. where we're going.
And I think I could be wrong, but that's what I think. And I think that's also why they are in the evening.
Yeah.
Because they'll make the plan that day, and then the teams will have to come down. And there's certain teams that will only do lungs or kidneys, or they might do all, but that's typically why there's more than one procurement team. So it gets real busy.
Yeah.
So are there I'm curious about this. Are there certain surgeons that specialize in removing those organs, or
I think that's
who's
all
part
they
of
do.
it? Really?
Yeah. So they'll just do organ transplant.
Yeah, they're just transplant
Yeah.
surgeons. Because they'll normally bring a transplant surgeon here.
Yep. And they'll typically have their assistant and then their scrub tech.
Mm-hmm.
I think a lot of people don't like doing them. I mean, number one is because it's hard emotionally. But it can be a lengthy process, but you're just helping. Yeah. I think they're self-sufficient. They'll come in and say, we have this, this, and this. So they might need specimen cups or more sponges or more this and that. So you're kind of just helping facilitate what they're already good at.
Yeah. Have you ever been a part of a donor walk?
Yes. That gets me every time.
Yeah.
That's the hard part. And I will be very honest that when I go get a patient from ICU, I don't even make eye contact with the family. Because it's heartbreaking. Especially for the DCD ones where they're the last one that we did, the patient's eyes were still open and blinking. And a part of you feels like, should we be doing this?
Yeah.
And then the family's there and you're walking and they're all crying and you can hear them because some of them are pretty hysterical. I would be too if that was my family member. But I just, for my own well-being, in order to do my job, I can't make eye contact with the family. Sometimes I get teary-eyed, but I just try.
Yeah.
I couldn't imagine. I'd be boohooing like a baby.
I know, it's not easy.
Yeah.
And like I said, that one in particular, the last one I did was just hard because the patient he was making noises the whole time, and when you're pulling off the drapes, he was wincing like he was in pain, and I was just right to the end of it, I'm I still felt like we shouldn't been doing it, but according to I'm sure they're 100% following protocol.
Yeah.
They wouldn't be doing it if they knew it wasn't the right thing, but a part of you're being a human being, you're ugh, it's hard. It hurt him to pull the drapes off. You're he's there. I know he is. So that one was hard. That one was really hard.
Have you ever had an instance where you did that and the patient didn't pass and you take them back to the ICU and they wake up?
I don't know. Because once we take them to ICU, we're kind of, I don't know what happens.
You pass off. Yeah. And the ICU nurses.
Yeah. I would hope not. I mean, when it says don't read the comments and you do read the comments, there was a thread that I read once where the patient did wake up and the patient was the patient not in the comments, but on that thread was saying I was the patient. They took me to the OR to take my organs and I woke up and you read that and you're that is terrifying. So I don't know what missed or how they even got that patient to the OR for that. But I read that once and I was I don't need to read that again. It's just terrifying. I would just hope that, like I said, that all the things have been done correctly so that patient was going into organ donation because everything was appropriate.
Yeah.
What's your favorite part about being an OR circulator? What's your favorite part of your job?
That's a good question. I honestly just like how fast paced it is. I love working with people. I could never be on a floor working by myself. I think that I would get so bored. So I think it's super cool that we work so closely with anesthesia, with surgeons, scrub techs, pre-op PACU. I just think that's really cool. I also just think it's really cool. When I was in school, I had an instructor that, and I'll never forget this, she said that when you're on the floor, you typically have a patient for, a full day or 1 to 3, if not longer. So she's you have all that time to make an impact on that patient. And one of the instructors that I had for the OR was you have 5 minutes to make that much of an impact on that patient's care. And I just think that that's really cool because it's true.
It is.
We have to go to pre-op and you're with a patient that might be super nervous. They're super vulnerable because they're about to go get put under for surgery. And so you just have a very tiny window. And I think that that's a really cool part, that they they put a lot of trust in you in that 5 little minute window of, hi, I'm Jenelle. I'm going to be with you for surgery. And because once they wake up, they don't remember because
anesthesia.
Yeah, exactly. So I think that part's really cool. But the team dynamic is what really does it for me. I just think it's super cool that you can work with.
Well, you have the most comforting tone and just like demeanor.
Thank you.
And I love when you're in the OR and I walk in, I'm like, yes!
Oh, yay.
Janelle!
Thank you.
Yes. But if I was a patient, like you would bring so much like peace to walking in. So definitely.
Yeah. I hope that, I don't know. I just think it's like, it's just such a, like I said, vulnerable, like those surgery scary, a lot can happen. And if I can be, if I can make a patient feel at ease or peace just because I'm there with them. And like I said, and I'll tell them like, I'm going to be there the whole time. You're not going to know, and a lot of them just laugh about that. So
yeah,
that's good.
Yeah.
So what do you think makes the difference between a good OR circulator and a great OR circulator?
Yeah.
What makes somebody great at that job?
I mean, I think that, that's a loaded question. I work with some really great circulators. I think a lot of people I work with are great. I have definitely worked with some not so great ones. I think that you just really have to want to be in the operating room. Mm-hmm. It has to be something that you're passionate about. It's such a specialized form of nursing. I don't think most people would make it very far in the operating room if they didn't want to be there.
Yeah.
And I'll say it's even for floor nursing too. Like there was this one nurse, it was when I was in school, and she was awful and she was so young. And I was just like, there has to be something out there that you would want to do that isn't nursing.
Yeah.
Because she already just seems so tapped out. But it's the same thing with OR nursing. Like I just hope that if you do start to get burnt out and you're not that excellent OR nurse or any nurse for that matter, I just hope that you maybe look at a different route, because in the end, it's about the patient.
Mm-hmm.
And I think every patient deserves an amazing OR nurse, but I just think it's the ones that want to be in there, that always want to learn, because we're forever evolving with technology.
Yeah.
Mm-hmm.
I think that's a really cool part of OR nursing too. But yeah, you always have to, you always like accept criticism, because you with the team dynamic, people are always going to be, giving you feedback and stuff, but it's just the ones that want to learn, that want to be there, and that want to grow. I think, that don't become complacent.
Mm-hmm.
I think those are the ones that make a great circulator.
Yeah.
Adaptable and moldable.
Yeah.
For sure.
Yeah.
The ones that like I see that just always are so in tune and anticipating like next step, like what's the next step, what like in tune with the surgery, the case, what does that surgeon maybe need, what could I maybe like get that can help them, like or just and being like over prepared.
Yeah. And that's what's going to save you in the event of an emergency. Like if you're looking on the screen and you're like, that's a whole lot of blood, like I'm off my chair. I can't really sit anyway, but I am like, you're getting things, are we going to open? Are we going to need the suction? Are we going to need laps? Like things that you're anticipating. You might not need them, and then it's annoying that you have to put everything back. But
isn't that like a huge misconception with reality or like grays or whatever? I mean, yes, open surgery is a little different, but like ortho, soft tissue, like it's not really super bloody. Like surgery is not like a lot of surgery. I mean,
you're right though. You're right.
Like,
yeah.
Ortho it's.
I think it's more tissue.
More
tissue.
Ortho
is
greasy tissue.
But like, I
and
feel
bone.
like there's this massive misconception that like surgery is just so like blood
it's so true.
and guts and gore and like.
I mean, every once in a while, you got like they're malleting that femur in, and it's like
totally
on their helmets. But
I think the reason why that misconception is there is because when it is bloody, it's real bloody.
Yes.
Because it's typically they can't control the bleeding.
Mm-hmm. Yes.
But you don't want to see that. Like you want the controlled bleeding. Like,
yes.
Okay, that's not bad. We'll take that.
Yeah. Yeah, that's true. I mean, it is. It's just like.
Or maybe we're just so used to it that we think it's not a lot of blood.
True,
That's what I'm thinking.
But I find it funny, like in the robotic rooms, when you're looking at bleeding, you're like, I kind of start to freak out, but you have to remember that it's just it looks a lot bigger on the screen.
Yeah.
But when I'm rarely in that room, and then I'm like,
Yeah.
are we going to start bleeding? Do we need to open? But it's just because
Yeah.
it looks a lot bigger on the screen than
Yeah.
it actually is.
Have you ever had like a conflict with a surgeon you've worked with, or have you had a really great surgeon that really has made an impact on you? Or talk about kind of like the dynamic between OR circulating nurse with surgeons.
Yeah, I am curious about that because, like, as reps, like, we build such a relationship with the surgeon, and I know like their teams do too, and like that's how they like form those preferences of I want this team, I want this nurse, I want this scrub. Like,
I think that it's super. I mean, I think it doesn't matter what any surgeon that you're going in, you definitely have to prove yourself. Does it suck? Yes. But also you're in such a closed room with a huge sterile field that surgeon wants to make sure that you can competently do your job. But I enjoy my day more as a circulator when I have more of a relationship with the surgeon. I feel more at ease. I don't feel like I'm standing there like this waiting for them to ask for something. So like in my ortho rooms, granted, I also know what they're going to need, and that also helps. But I don't know, you just feel like you can ask them a question. You can, like doctor always asks me about how's Frankie, how's my dog? And I'm like, I just love that. But it makes a difference. If it is a surgeon that I am not, that, we're not BFFs, whatever, I just go into that room and I just do my job. As long as I can do my job, they really can't complain. They might not love that they don't have their nurse in there, but I can still, if I can just do, do the best I can, really is all that they can ask for. But it does, like neuro's not my strong suit. I don't love it. It's not a specialty that I love. I'm okay in the rooms, but I will tell you that when I go into those rooms, I'm like on guard. I'm like, all right, I'm like ready to go and run with whatever they need. Like, I just don't feel as relaxed as I do in some. So it does make a huge difference.
What's your approach when you have a mean or sassy surgeon? Do you like sass back? Or
they're so picky too. Like they're like, where's my nurse?
Where's
my nurse?
Like when y'all are like sassy back, like, excuse me.
I love it too. I love it too.
I at first will read the room. Like when I'm with a brand new surgeon that I've never worked with, I'm usually pretty quiet. Because there are certain surgeons that you can give it back to without getting in trouble. But there's definitely some that will probably go straight to charge and be like, get that nurse out of my room. But also, I don't work for the surgeons. I work with them. And I think many nurses will say that. So it comes back to that team dynamic of respecting each other's. I have a job as an OR circulator because the surgeon can't do it without me. Surgeon can't do it without a scrub tech. They can't do it without anesthesia. So I just think that there's a level of respect that we should each be given to each other. If my patient is bleeding out and they are like yelling for things, go for it. But like if we're doing a very simple surgery and you're going to yell for something, I'm probably going to give them attitude back because it's like, calm down. You don't need to yell because you need a new scalpel handle. Do you know what I mean? So there's a time and a place. But I think that I get along better with the surgeons that you can give it back because I just find that their personalities are typically more laid back. Like, you can give it more, or
you can get it.
Exactly. So,
I love when the rooms are like that and they're just too. This is so fun.
Or I love when, like a nurse is relieving for a lunch or whatever, and they walk in and they're like, what happened to my nurse or whatever? And the nurse is like, what am I, chopped liver? I'm like, give it to him.
Exactly.
What are your pet peeves with reps?
Oh, good question.
Or what is what do you think is important for reps to, like, your top advice for reps when they're coming into an OR?
I'm not just saying this, but I really do think that the reps at Hendrick are phenomenal. I'm in ortho a lot, but like neuro are freaking awesome. Everyone's great. I haven't had a bad rep in there, but there are some bad reps that I have worked with. I just think I say more so they're super important for the scrub techs if they're not familiar with the sets. So I like to see reps that are interactive. In ortho, they're usually like, put this and together, grab this. because if they do their job well, scrub techs do their job well, surgeons are happy.
Mhm.
And I think that that's really what
And
boils.
patients get good.
Yes,
Yeah.
exactly. The procedure's done more efficiently. It's not, there's no
Mhm.
delay. But I honestly haven't had a bad experience with the reps here.
Good.
Yeah, they're super great.
Good.
Most of them are
Awesome.
kind, you can have a normal conversation with them. It's not just business.
Yeah. Yeah.
So
That's awesome. That's good. Yeah.
That's how it should be.
I love all the reps. I mean, like, I interact with all the reps with all
Mhm.
different
Yeah.
specialties. at
All
the
of them.
hospital, and
Yeah.
everybody's great.
you'll get a hard time. Like always, like when you come to neuro, I'm like, never.
Yeah. That's how I feel. Come over here.
I know. I do love a good groom. I miss that
I
man.
love him.
I know. Me
I
too.
do. I know he's a different breed of personality. Some people are like, I do not want to be in
I
that
was
room.
terrified to be in his room when I first started.
Yeah.
And then during my
Why?
orientation, I don't know. I think it's just the hype. Do you know what I mean? It was,
Yeah.
everyone was like, oh, so it was like, you go in there and you're already like shaking.
Mhm.
But they're all big teddy bears. I don't know.
Yeah,
you know?
he is, for sure.
Yeah.
I was gonna say, I sometimes find that the ones that intimidate you the most in the beginning are some of the like nicest. If you
They
just
are.
sit there and get to know them. Sarah
Exactly.
and I talk about this all the time. At the end of the day, surgeons are
Are there
humans
people?
like we are.
Exactly.
They're people
Yeah.
like we are.
Yeah.
Can some of them be jerks and a little more
Absolutely.
sophisticated? Yes,
Yeah.
but like most of the time,
Yeah.
Yeah. And those
they're-
are the ones that I just don't really care to. Like, I'm like, we don't need to be friends.
yeah, I'm
Like,
just like
You do
okay.
your job, I'll do
Mhm.
mine.
Yeah.
Yep.
Don't yell at me for something stupid and we're good.
Yep.
But
Yeah.
like there's
Yep.
other ones that I'm like, I know that you're a teddy bear under there and I'm
Yeah.
gonna get to
Oh,
know
yeah.
you.
Oh, yeah.
Can we be besties?
Yeah.
Right?
I love when surgeons can have like good camaraderie.
Right? Because it's
their
just
attitude sets the tone. for
It
the
really
OR.
does.
Like it really doesn't matter how the team, like,
Yeah.
you can be a freaking badass team, well-oiled machine, and like have fun, and but that surgeon walks in the room and they set the tone.
I know.
It's like,
They really do.
You can have a great time before where you're prepping, and
Yeah.
then wheeling out,
Yeah.
But I mean, if the surgeon during the case doesn't have that,
Yeah,
it does.
it really does.
Yeah.
That's why it's like I don't know, I would rather work in a team, like with the surgeon and his team, because then you're like, they're probably going to be in a better mood than if they're not. And I'm like, so that's why when the charge nurse does that, you're like, thank you.
Yeah.
We're gonna have a great day.
Yeah.
Yeah. That's awesome. What is one of the funniest things that has happened to you in the OR?
I laughed when I saw that one. Okay, so I was back in Canada and we were getting a patient positioned for a total hip,
Uh-huh.
and it was lateral, whatever, side up.
Mm-hmm.
And I was standing on the side with the front side.
Yeah.
And the surgeon and the assistants were all up there kind of doing that thing. And patient was flipped this way. I was like, oh, it kind of feels wet. And I looked down.
No.
The patient was peeing, and it was you're in these stupid blue scrubs.
On you?
Yes, on me. And it was like right here where it looked like I would pee myself.
Like you peed
yes.
yourself?
And it was
Oh,
Dr.
my.
Burkhart, and he was like, would you go change? I'm like, yeah. So I walked out of the room like laughing hysterically, and there was 2 reps waiting to come into the room. And they were like, what happened? And I was like laughing way too hard to even explain what happened.
Uh-huh.
And so I went and changed whatever, and then came back in the room. And like for 2 weeks after that, people were like, I heard that you like peed yourself. And that was the rumor. And I was like, that was not my pee. Like the patient peed on me. So I don't know if the reps, I don't know where that rumor
They
came from.
so did. They so came up with
Right?
that. Mhm.
I was mortified. I was already mortified having to walk to the change room with like a pee mark like this. But I was like, why does it feel warm? And I looked down and I was like,
Why do I
oh my
feel
goodness, you're
wet?
kidding.
Oh my
But it
god.
was like for 2 weeks. People were like, that's not true, right? And I'm like, do you think like, no, I didn't pee myself.
I'm
Like,
a
it was
grown
someone
woman.
else's
I'm not
pee.
like, oh my gosh. that
And it was
is
so fast. And I was
funny.
in a hurry to get back to the room because I was like,
Yeah.
I have to finish circulating.
Mhm.
So I didn't even think to like explain to the reps what happened. I just like walked out laughing, and they
So
were
they
like,
started a wicked
probably.
They did.
rumor. That is so rude.
I know.
jerks.
Right? Big jerk.
Those dang
Wow.
reps.
I'll never forget that. I was just like that. Yeah. So next time, if that happens, I'm going to be like, everyone, do you see? I got peed on. It's not my pee.
Uh-huh.
It's
Because
not
for
my
2
pee.
weeks, I was like that. Yeah, I didn't pee myself.
That is so funny. Oh my gosh.
That is hilarious.
Yeah, that's funny.
And
I'll have to tell you a story. I can
Yeah,
not say it
same,
on
but I'm
camera.
not going to on here.
I cannot tell you this on camera, but that's funny.
Most memorable surgeon quote. Also, because the scrub tech we had on, she was talking about this. Do you have any nicknames that surgeons
For your
call you?
surgeon.
Or, yeah.
Dang.
Or like,
Or a funny quote or something that like is always said. That's funny.
A doctor, he'll always say, we do it the same way every time unless we do it different.
well, what the hell does that
I
mean?
know. So it's like, does it the same way, but then as soon as they do it different, you ask, and he'll be like, we do it the same way every time unless we do it different. And it just makes you want to like,
Okay.
You're like,
okay,
thank
whatever,
you.
thank you.
We're
'Cause-
fucking with my brain because I have no idea what this means. Okay. That's funny. That's
Right?
good.
Because it
That's
is
good.
true. Like they will do it the same way, but as soon as they do it differently, then you're like,
Why are we doing it?
why are we doing it? And then what do I need? Like you're just like, okay, I don't know what we're doing now. Because you're so used to doing it one way.
Yeah.
And it's just like,
It's
So
true.
you're not allowed to do it different.
It's the same
It's
way.
true.
Yes.
Unless we do it different.
Why are you changing it up?
That's really funny. Wow.
Uh,
Oh my gosh.
Yeah. He says it. I think they all say a lot. Or he'll be like, oh, he's going to love it. Like when they're doing robotic knees.
Mm-hmm.
And they're like, yep. Oh, he's going to love it. Next patient. Yeah, he's going to love it.
Oh my god.
But I do like that we do it the same way every time unless we do it different.
Unless we do it different.
So you're like, you'll be opening stuff and he's like, I don't need that. And you're like, and he's like, we do it the same way all the time unless we do it different. You're like, okay.
It's like, well, apparently we're doing it different. Oh my gosh.
Yeah.
So how do you respond to that?
Then I'm just like, okay, well, what do you need then? Because typically you're looking with this at the scrub tech and you're like, I don't even know what we need. Typically, the reps are actually fantastic because
Okay.
they'll be like, okay, we're doing it this way, so you'll need this,
Yeah.
this.
So
and
they
this.
know the different ways.
They know the
Okay.
different ways.
Yeah.
Yeah. My brain is like, we're doing it this way, and
Unless we do it
all-
different.
Damn.
so we have these little set screws, right? And one of the surgeons we work with, my colleague, his name's Chad, and he always calls them Chad's nuts. He's like, can I get Chad's nuts, please? But when I'm in the
Oh,
room,
gosh.
the first time I was in their covering room, he's like, can I get the nuts? Because he won't call them mine or Chad's. I'm like, you can still call him Chad's nuts. He's not here,
He's
but we'll
not-
still use
well,
them.
yeah.
Oh my gosh.
Or there's Tom. He's one of the Zimmer reps. We have to open up like the femoral heads. We call them balls. So he'll always be like,
Mhm.
hey, can you open up my balls? Like, gotcha.
I love that.
Yeah. What is something that you wish patients knew about the OR or that happens in the OR?
I just hope, like, I know that when we go get them, like, obviously they're super nervous because it's surgery, and especially if it's your first surgery. But I just think that we work in such a specialized area of nursing because we really want to. So I just hope
Mhm.
that they all know that we got them. Like when I say we'll take good care of you, we will.
Mhm.
And y'all really do.
Yeah.
You do a phenomenal job at taking care of them.
And so, because I
Yeah.
feel like you don't go into ICU for the fun of it. You don't go into the OR for the fun of it. Like you go there because you want to be in that specific area. So,
Mhm.
when we say we're going to take good care of them, I just hope that they know that we got them.
Yeah. I love that.
Mhm.
Oh. And it is so true. I mean, y'all are such a blessing. And I personally think like the team, because it's normally anesthesia and circulator that rolls, right?
Yep.
Okay. Yeah. Like if those two are kind of like they've got great camaraderie.
Yes.
And they're really just kind of
It's-
chatty
yeah.
and making me feel like I have surgery now. I would be requesting the team.
Mm-hmm.
It's like you want to go
No, you
to the
do.
surgeons that you
that
know are good,
and you trust.
but then you're like, should I know all their team?
I literally like think about
like you're
this.
all gonna be looking at me. Mm-mm,
Yeah. I'm like,
mm-mm.
I would rather drive to Dallas and be with a team that is never going to see me again.
Yeah.
Janelle, thank you so much for coming on and just
Thank
yapping
you.
Thank
Yeah,
you.
and sharing all about
Fun.
your incredible
Yeah.
profession. Thank you for what
Absolutely.
you do for patients, and
Thank you for
Yeah.
what you guys do too.
thank you.
Of course. And also, isn't she just gorgeous?
I know, glowing.
Anyways,
Glowing.
thank you for coming on
Okay.
and tune in next time.
Yeah.